Thank you, everyone, for joining us today. My name is Rajiv Ramchand. I'm co-director of the Rand Epstein Family Veterans Policy Research Institute, and I want to welcome you to the webinar today. This is part of our bi-monthly webinar series focused on high-priority veterans policy issues. Housed at RAND, our Veterans Policy Institute has as its mission to conduct innovative interdisciplinary research to improve the lives of those who have served in the US military. We aim to publish and widely disseminate our research findings to connect objective and rigorous analysis to decision makers so that we can improve evidence-based decision making. RAND also has its graduate school with campuses in Santa Monica and Washington, D.C., that offers master's programs in national security policy and technology policy, and also master's and doctorate degrees in policy analysis. And I mention that because I'm really pleased today to introduce my colleague, Ben Senator, who is a doctoral candidate at the RAND Graduate School. Ben will present new research findings from a report we released yesterday, funded by Face the Fight, on the veteran suicide prevention landscape. Ben's presentation will be followed by a few comments from Justin Schmidt from Face the Fight, and then I'll come back to moderate a panel discussion with our guest experts, Craig Bryan, Katie Dondonville, Gabe Hessler, and Dave Gowell. A few quick housekeeping items before we get started. I realize I'm going quickly. I just want to make sure we get to the content and the meat and less of meat. We have a chat feature open, so please feel free to ask questions or share resources that the audience may be interested in. To ask questions to the panelists, please use the Q&A feature. We'll monitor that, and we'll try to get as many questions as we can. That said, we have a huge attendee list, so we probably won't be able to get to everyone's burning questions, but we'll try to get to as much as we can. Thanks for attending this really important, this really critical webinar today. And with that, I'm going to turn it over to my colleague, Ben Senator.
Thanks very much, Rajiv. Heather, I think we can skip through the first 5 or so slides just to catch up to the content. Yeah, one more. Perfect. Thank you. So for the past 20 years, the number of veterans dying by suicide has been an ongoing source of pain for the United States. Since 2001, more than 6,000 veterans have died by suicide every year. And the rate of suicide among veterans has been higher than non-veterans since 2001, with the gap sadly increasing over time. Next slide, please. So with these statistics in mind, preventing veteran suicide has been a continuous national priority for government, advocacy groups, and the private sector. Many individuals and organizations continuously work to leverage their expertise to create, expand, and promote activities that they hope will prevent future deaths. And whilst these veteran suicide prevention strategies work towards a common goal, rapid technological advances in medicine, data science, AI, and pharmaceutical engineering, to name some, has seen a diversification of the approaches taken towards suicide prevention. Next slide, please. So given this, there has been a serious need to take stock, to build a framework of the current and emerging approaches to veteran suicide prevention, answering questions such as how do diverse strategies for prevention complement each other? How are they changing through times of significant technological advance? And does the evidence suggest they will ultimately work to prevent future deaths? As Rajiv mentioned, RAND's research on these questions was funded by Face the Fight, which is a coalition of corporations, foundations, and nonprofits joined together to raise awareness and support for veteran suicide prevention. Next slide, please. So the RAND team conducted a landscape analysis of veteran suicide prevention programs, found through 2 approaches, a web scraping exercise and the extraction of lists of successful and unsuccessful applicants to the VA's Mission Daybreak competition and Face the Fight grantees. This yielded 307 programs in total, 156 are currently operating, and 228 were proposed to funders, some of which were ultimately funded. Our final list will not be comprehensive of every single veteran suicide prevention program in the United States, but the robustness of our approach means that these programs will more than likely represent the vast majority of veteran suicide prevention programs in the country. Next slide, please. So across these 307 current and proposed programs, we were able to identify 26 categories of suicide prevention activities that worked across a plethora of areas, from community partnerships and social connection programs through to means safety training and psychological treatment, and so on. In just a moment, I'll be touching on 3 of these categories that I consider to be particularly demonstrative of applications of technological advance. Next slide, please. But before I go into these examples, I first want to highlight how we've begun to understand this diverse landscape of approaches to suicide prevention. On the left, we considered a simple extension of the socio-ecological model tailored to veteran suicide prevention activities to showcase that prevention efforts don't just target the veteran. Veterans exist within their community and indeed wider society, and suicide prevention efforts can be seen across all these social ecologies. On the right, we took the common approach, the common idea of a disease prevention model and reconsidered it for veteran suicide prevention. At the highest echelons of this pyramid are targeted approaches, mainly crisis response, focusing on individuals at heightened and acute risk of suicide. As one moves down the pyramid, the suicide prevention activities become less selective and more universal, such as mental health supports and interventions that focus on the general well-being of the veteran. Next slide, please. When we put these together, we arrive at one of our central frameworks for mapping out the landscape of veteran suicide prevention strategies, which we call the RAND matrix of suicide prevention. As is discussed in much greater detail in our final report, we found that our 26 categories of prevention can be seen working across all socio-ecological levels of the veterans' lives and across the spectrum of targeted versus universal interventions. Some prevention approaches work across multiple of these levels. Means safety activities, those that put time and space in between a person at risk of suicide and the means used to take their own life, such as a firearm, can involve working at the level of the veteran as an individual in moments of immediate crisis through things like lockbox technology. But they can also work at higher levels, such as the community, when veterans' family, friends, and healthcare providers are encouraged to openly discuss safe firearm storage with them. Next slide, please. So most of the programs we reviewed fell under these traditional categories concerning social connection building, case management, and non-crisis psychological counseling, often operated by non-profit organizations. But as mentioned, there are examples of suicide prevention categories that showcase how technological advance is changing how and what these programs offer. Next slide, please. One more. Thank you. So one example of this is real-time monitoring. A number of organizations that we reviewed are offering advanced technologies that can monitor dynamic changes in a veteran's mental health status in real time. Those technologies, such as wearable smartwatches, will alert the veteran or the veteran's immediate carers for timely intervention at times of crisis. Now, notably, research has yet to tie the use of these devices to a reduction in suicide outcomes, mainly because this use of technology is just too new for robust evidence to have been generated so far. Although our report does find that they appear to have a modest ability to detect genuine real-time suicide risk spikes. Next slide, please. Another example is suicide risk assessment. Traditional suicide risk assessment tools have used screeners and questionnaires, relying on the veteran to self-report their own suicide risk, raising concerns around the accuracy and reliability of screening. But technological advances aim to complete these assessments accurately and moreover without physically engaging the veterans themselves whatsoever. This has been seen through the application of advanced machine learning methods to, for example, health records and social media data, producing categories of risk for carers to then use. Evidence suggests risk screening is effective at identifying individuals at current risk of suicide, but the evidence for whether these tools can predict future risk has yet to be concretely seen. Next slide, please. And so as a final example, we saw a range of apps and websites that work to integrate many services into one virtual platform. We call these platforms multifunctional digital health platforms. They often saw connections with trained clinicians and peers, education on suicide and firearm safety, and crisis intervention resources. And whilst we saw a lot of these programs, a likely limitation we considered is that veterans simply don't know about them. It's not necessarily that if you build it, they will come. Rather, dissemination and marketing will be a crucial step for higher engagement and subsequently the development of evidence on their outcomes. Next slide, please. So to conclude, veteran suicide prevention receives significant attention from a large range of stakeholders working across veterans, their communities, and society writ large. Novel technologies are being used to both augment existing suicide prevention strategies and create new ones. Approaches currently include both traditional and novel activities, but we're lacking some good, robust evidence on whether these novel approaches are decreasing suicide prevalence and risk. Monitoring the evidence over the coming years will be an imperative for understanding how we can best reduce the number of veteran suicide deaths each year. And with that, I will hand back to Rajiv to carry on.
Thanks so much, Ben. I'd like to introduce Justin Schmidt from USAA and from Face the Fight to add a few words before we get into our moderated panel. Justin.
Thank you so much, Dr. Ramchand. Can you hear me okay?
Yep.
Okay, outstanding. Welcome, everybody. We are so glad to be able to present this incredible panel and to discuss the incredible RAND research that is underway. And I'd just like to share 3 dates for your awareness. So 1922, 1946, and 2023. What in the world do these dates have in common? Well, in 1922, USAA was established by 25 Army officers because they were trying to solve a problem. The problem was that they were considered uninsurable at the time. So they had the audacity and the initiative to create their own company. That was the seed of USAA. In 1946, after World War II, RAND was created to harness some of the nation's best brain power that won the war for our country and to continue to use that brain power for good. A couple of years after 1946, they turned into a nonprofit, and they have grown and emerged as such an important authority for research and data that provides insight, that drives action, and creates conditions for our country to continuously improve. And RAND has demonstrated that time and again over the years in support of military and veteran caregivers, and more recently with Face the Fight, which brings me to 2023. USAA, along with Reach Resilience and Humana Foundation, and side by side with incredible partners of UT Health San Antonio and the Elizabeth Dole Foundation, created Face the Fight to marshal resources from the private sector to supplement those of the DoD and the VA that do such important and critical work for our nation's military community and for suicide prevention specifically. As a result of Face the Fight's efforts, just shy of 2 years after launching, grant making is an important component, and we are currently estimating approximately 6,500 U.S. military veterans' lives saved as a result of scaling evidence-based programs through Face the Fight grants. We are not doing a lot of research through Face the Fight, but we are doing one research project, and that is with RAND. That's the report that you'll hear from today, and will be analyzed and presented in more detail by the incredible panelists. So I just wanted to say thank you to our teammates at RAND, our teammates at UT Health San Antonio, and the Elizabeth Dole Foundation, and in particular, Dr. Dondanville and Dr. Ramchand, who are co-chairs of the Face the Fight Scientific Advisory Committee. We are tremendously grateful for your expertise. We would not be doing what we're doing without your involvement and expertise. And over to you.
Awesome. Thanks, Justin. I appreciate that. I'm not going to introduce, we have bios in the invitation link for you all, and we're just so grateful for Face the Fight support for this effort. The bios of our panelists are on the link, so I'm not going to introduce them all by name, and I'm just going to get right into it because I think that we're going to have a lot of questions and a really dynamic discussion. So I prepared some questions, and please, if you populate the questions, we look forward to seeing them in the question and answer or in the chat. So Craig, I'm going to start with you, Dr. Bryant. Ben just mentioned this new technology of suicide prevention interventions, real-time monitoring. And I have to admit, it's very exciting to me, and partially because I've heard you talk about the fluid vulnerability theory of suicide, how risk can wax and wane. It's not just people who are at risk, but time periods that are at risk. So if we can identify time periods at risk, it seems like we could deliver some really useful kind of interventions at times of heightened risk. But in 2022, a few years ago, you said, we should be a little bit cautious about this technology. I wonder, if you could restate kind of what you said in that article, and restate what you said in that article, and then also just kind of say, is that true? Do you still believe that, or has technology changed, or your theories changed?
Yeah, yeah, sure thing. So I think I could answer the last question reasonably straightforward, and I do still feel the same way. The argument that I made is that this is actually a little bit, or perhaps a lot more complex than what we think. And so, yeah, the idea of just-in-time adaptive interventions, or JEDIs, as they're often called for short, is that, when we recognize that someone has moved into a vulnerable state, we send an automated intervention of some form or fashion to them to hopefully knock them out of that vulnerable state, or otherwise stop their progression towards suicide, hopefully before it's too late. The reason why myself and the co-authors, my colleagues on that, said, hey, perhaps we should temper our expectations about this, is that we actually don't know what would be the right thing to deliver at what time to who. And when we look at other health outcomes where technology has been used to do JEDIs and other interventions like this, there's actually some really important findings that if you don't pick the right thing at the right time, you can actually inadvertently get the opposite of what you want. So, like with smoking cessation, researchers have done this and found that in some cases, sending an intervention that seemed like a good idea actually increased smoking as opposed to decreased smoking. Same has been found for other substance use conditions. And so we're finding this right now in our research, where we often think about suicide prevention as when someone's in a vulnerable state, deliver the intervention at that time. What we're now seeing with like our EMA research is actually that's probably the least effective time for an intervention, because someone's so acutely distressed, it's like too late at that point. So like wait for the house to be on fire, then try to put up fireproofing around the house. And so we're seeing that it's actually more about getting people to use strategies and interventions before they actually get to that point, when it's actually a lot harder to see which trajectory they're following. And we're also seeing now as well that different people use different things at different times. And so there is this personalization element that's really important. And so yeah, so I think there's a lot more work that needs to be done here, and we should be cautious, because if we send the wrong thing to the wrong person at the wrong time, we actually might increase their risk inadvertently.
That is super fascinating. Thank you for sharing it. It does temper our expectations, especially if there's harm that could come from it. David, I want to move to you. You're CEO of one of these technological innovations, Rally Point, which you're going to be able to describe better than I can, but very briefly, a social media platform for service members, veterans, and their families. As CEO of Rally Point, that's really meant to connect these communities, what made you think, maybe we have something here that we could leverage to inform or help prevent suicide?
Absolutely. And thank you, Rajiv, so much for having me today. And also thank you for inviting this great panel. I'm always learning for Craig for many years, including just now. So I continue to try to figure out how we can play our part in the space. We did not expect to be in the suicide prevention space when Rally Point was born. We were initially a place where service members could connect with one another as a way to get outside the chain of command and help each other with careers, promotions, and challenges that aren't always easy to talk about in uniform or with your leadership. The military leadership chain of command is not as easy to work with sometimes as the civilian chain of command. And so when LinkedIn was growing and becoming successful, we recognized that, well, LinkedIn wasn't really going to work for the junior enlisted military. Then we found that the trust that our audience built with each other allowed them to start sharing things that we didn't quite know how to deal with. And Ben, I appreciate you sharing some of the things you talked about, the AI work that we're doing. And because in our prep work, we were asked to consider sharing some resources, I'll drop in the chat one of the posts the VA used on Rally Point to stimulate that predictive modeling. The idea of asking the audience, how have you struggled? And seeing how they react, and specifically saying that the VA was doing this in a public setting on Rally Point, knowing that when people share their struggles, they will be met with, somebody looking for people who are sharing significant risk, but also ideally people sharing solutions and the ability to have peer support, helping one another find what's worked in ways that maybe the VA hasn't solved yet, and so that they could learn from veterans and help each other. So we're trying to play our part by connecting people, doing research, learning from great folks like those on the call today, and eager to keep trying to do more.
Thank you. Thanks. That's awesome. We're going to get back to that because I have a follow-up, which will be a good follow-up, I think. But I want to get to Katie next. Katie, in addition to the work that you're doing for Face the Fight, you're also you're director of the Strong Strive Training Initiative that has as its mission to really train providers in evidence-based strategies for mental health as well as suicide prevention. So you interact with a lot of providers, I'm assuming, and I'm just curious, how are they receiving these interventions? Are they recommending that people go out and stop monitoring their biomarkers? Are they recommending they use apps like whether they're meditative apps or mindfulness apps or something even more intensive that I don't know about? Or are they afraid of them? Are they worried that it's kind of could be, as Craig said, perhaps in the worst scenario, kind of risk creating? What's kind of the appetite in your mind for these types of new technologies that are emerging in the mental health space?
I mean, my experience with clinicians is they are really interested in better serving their clients. I think the adoption of sharing apps, psychoeducation, resources, the VA really has led the development of so many. And now there are, the mindfulness, things like that, I think are things that are very commonly recommended as complementary. I think, thinking about these new technologies in these wearables, what's still unclear, I don't think they're as widely accessible. Like, in the presentation, if you build it, they will come. Like, there still needs to be kind of efforts to get them out there. But then the second piece is we need guidance on how to use them in our therapy. So I think to Craig's point, it's complex, and that if I had a client that had a wearable and could show me all their data, I'm not sure that we really know what to do with that yet. And so I think as new technology is being developed, we have to create clear guidance on what does it mean? How would we use it? And I don't know that we're there yet, because I think clinicians could be really helpful in getting it out there. Helping to recommend products if they knew how to use them, they were easy to use, and they knew how it would connect safely with their care.
Thank you. Gabe, I'm going to turn to you now. And I'm really excited. We were putting together this panel. You were co-author of a paper that came out, and I have to mention you were co-author with two researchers at RAND that I always work with often, Beth Ann Griffin and Lindsay Eyre, and who are just awesome. But in your recent paper, you said suicide prevention researchers need to, and I'm quoting this, move beyond statistical significance. And I'm just curious, what do you mean by that? Have we been too stringent? Have we been too lax when we describe something as evidence-based?
Yeah, thank you. So, I mean, that paper in particular was focusing on this idea of when you do some kind of research study, whether you're evaluating whether a program works, or you're trying to find either associations between, some characteristic and your outcome you're looking at, in some cases, suicide or suicidal ideation. We often in the literature focus on, is this result statistically significant or not, as this binary classification based on, often whether or not your p-value, which is this actually very poorly understood statistical quantity. I mean, statisticians understand it, but it's a very non-intuitive concept. But anyway, but whether this kind of one number is above or below 0.05, which is this, magically chosen threshold, and that, the argument we're making, and this is not a new argument, this is one that, the American Statistical Association has been pushing, is that, this p-value that's, 0.0501 versus 0.0499 is, qualitatively the same number. And if we are making different decisions based off of these kind of minuscule differences in this number, that's not really where we should be. And we're almost, I don't know, we're delegating too much authority to this kind of single statistic. And so I don't know if it's necessarily a have we been too stringent or too lax. What we were specifically talking about is oftentimes, particularly when you're studying very rare outcomes, which, suicide is obviously more common than we would like, but at population levels, it is still quite rare. Ben talked about how, we just don't have enough evidence for some of these to figure out whether some things work or not, that it's even harder to kind of get things over this threshold, and that we should perhaps be a bit more forgiving with kind of the level of evidence here, and just understand that, given what we could know, given how rare these outcomes can be in some of these studies, requiring clearing this 0.05 threshold means we're leaving a lot on the table, likely.
Katie, Craig, I'm wondering if you could react to them both as researchers who published and perhaps have had papers rejected because of a p-value threshold. But more than that, I'm curious, Katie, you mentioned clinicians are wanting to know what to use with this evidence. Are they looking for evidence too? Do you think that we need to get these things evaluated so that there is evidence? And do you think that this p-value is kind of a barrier to getting things used in clinical settings that could potentially hold promise?
Well, I think a couple of things. One is like an average community clinician does not have access to the journals where these amazing articles are written and are reading in that way. So I think that's one thing for us to consider, like, where do clinicians get guidance on practice? And they come from clinical practice guidelines from their professional associations. And so I think that p-values and that level of evidence isn't necessarily where they're zooming in, but the products that they're looking at, like clinical practice guidelines, are looking at that. And so that is what influences what is recommended. Yeah, Craig, I wonder your thoughts.
Yeah, I was chuckling there because it was such a well-timed paper, because I'm quite literally in the midst of a conversation right now. We have a new clinical trial that just recently finished, and there are these very clear differences between the groups, like 75% difference in suicide attempts, and at least one of the analyses at 0.055. And so there are some others involved in the project are like, well, we can't report that. And I'm like, guys, like 75% difference. I mean, let's be a little real here. And all the other p-values met the magic threshold. So I do worry about like this purity aspect when it comes to this sort of rigid, kind of either or mindset that comes with that. But it occurs to me there's sort of another aspect of this that I don't think was a focus of Gabe's paper, but there's this sort of other problem, which is, as sample size increases, getting to that magic threshold is really, really easy. And so there are a lot of things as well with it, suicide prevention, that have statistically significant relationships or something like that based on this threshold. And you look at it as like a clinician or something like that, and you scratch your head. I'm like, is there really a relationship here? Is there really a difference between these two things? But because typically the researchers were well resourced, or they had access to very large data sets, they can sort of make these claims that don't really sort of match the clinical significance or the meaningfulness of the finding.
Thank you. David, I want to turn to you really quickly, because one of the other things that that and this wasn't one of the prepared questions, so I'm putting you on the spot a little bit. But one of the things that came out was this that Ben talked about is that sometimes, like, there's lots of apps that are coming onto the market, and we've been talking a lot about wearables, but I want to go into this app direction. I hear often about people who have an idea for an app or who are developing an app. But there's lack of awareness, and perhaps there's even something like app fatigue, that people are, maybe tired of downloading a bunch of things on their phones that they don't know whether will work or not. How have you at Rally Point kind of addressed the marketing aspect of your I realize your tool is more than just a suicide prevention tool, but how do you manage the marketing aspect of it to get veterans and service members engaged in your platform? And how hard is that? How much effort do you put into it? And then how much time goes in the back end of keeping it up to date so that it doesn't get glitchy and things of that nature?
Great question. And I would highlight one of the least common things Rally Point is to our audience is suicide prevention. We have made 78 suicide risk interventions total, which is not a lot considering 1 month alone in December, we had about 4 million unique visitors. Those people didn't come for suicide prevention. So the way we think about the platform, I think, as any private entity does, it's about competitive differentiation. What do we have? It's the trust of our audience to provide an experience that is patently veteran and military, to help them with their life challenges and to help them succeed. And so that starts when you're joining the military. If you're trying to figure out if the recruiter is telling you if it's true or not, you can actually talk to people in the unit, in the branch that you may be going to, and ask them. While you're serving, you can get outside your chain of command and ask questions. When you're thinking about getting out of the military, you can talk to other veterans who are a few years ahead of you. And then if you're a veteran and trying to navigate VSOs and the VA and healthcare and everything that is out there, you can ask other questions and also go back and look historically. We've been around for 13 years. So figuring out how to leverage the 82 billion data points that we have in a way that creates even more trust with our audience to give us more data where they don't have to pay for it. We don't sell that data, and we don't sell those data. We allow them to benefit from it. It's a constant exercise of figuring out how to provide more and ideally ask for less from that audience.
Got it. And just as a follow-up on that, and it is so they're trusting you and they're putting social media things out there, and we've been talking about heart rate and sleep quality. Do you think that an opt-in policy is like a significant? I mean, a lot of people are talking about the ethics of these approaches. Do you think an opt-in policy is sufficient? Where do you think kind of people's privacy and their ownership of their own data, like how does that play into all of these new and emerging technologies? I'll start with you, but please, if Gabe or Craig or Katie have any thoughts, I'd welcome them after you go.
Yeah, I think it's table stakes, but it's not enough. Nobody reads these things that you might be opting into. So you have to think through what you're legally required to do. Then you have to build an intuitive experience so that what people agreed to actually they know is happening, so there's no surprises later. Like you might have heard some email platforms in the past advertise what people were talking about privately. Like that's not cool. Like our predictive modeling doesn't in any way look at private messages on our site. You can send private messages. We don't look into that. That is private for a reason. And so having intuitive expectations met and then being aggressively transparent. So but once we got the Air Force contract to actually go forth and create predictive models to look for suicide, before any of that became public, we published, how do you think we should attack suicide using technology? We said what we were going to do. We let our audience share with us what they thought. And so I think there's a multi-tier strategy to using data and earning more data to be effective.
Katie, Craig, Gabe, any further? No, okay, great. That's a great response. So I appreciate it. We do have some questions populating in the question and answer session. So keep asking those if you have any additional. I did want to ask this question. The other thing about your response is that you had this people are not coming to face the fight, or I'm sorry, people are not coming to Rally Point for suicide prevention. It's kind of this added on thing. And I kind of have two questions. I'll ask the first one, which is, it seems like that's a really interesting opportunity. It's starting to embed suicide prevention, maybe outside of where it's traditionally been, which is in the mental health sphere, and putting it in other places. I'm curious if anyone on the panel has thoughts of that, but then also maybe on top of that, can we see in our report, we saw the private sector playing an increasing role, especially with these new technologies. Do you see more opportunity and more room for the private sector to start contributing to suicide prevention, whether that's embedding suicide prevention in their own practices or other things that I haven't even thought of?
So I'll respond quickly, and then everyone else feel free to jump in. But I definitely think we should all think about what suicide prevention is. I love what Craig said earlier. Like, let's not wait till the house is burning. Too many people, and I think historically, because we haven't had data and technology at the ready like we do today, we've had to wait. Clinicians have had to wait until suicidality was present to act. Now I think we can go upstream in ways well before the house is on fire to know when we're at risk. And that is, I think, where I think private industry provides speed. I think brands build trust more rapidly oftentimes than governmental agencies. And I think a lot of nonprofit and government funding often have very strict guidelines on what can be done, especially when you're dealing with suicidality moments, because you have to expose people to minimal risk when you're doing any sort of research. But if, for example, you're going upstream, you're connecting benefits programs, or you're trying to help people lead great lives and be successful and keep them from becoming suicidal, well, you're not dealing with risk. You're trying to keep people from getting to a risky place. And I think that is the opportunity now. I think we want to highlight how veterans can have growth after traumatic experiences in the military, and why everyone in their community should want to join the military, because most veterans aren't suicidal. I think that's a key message, that we don't want everyone in our communities to think, oh, veterans are homeless and suicidal, because we all aren't. It's just we care deeply about those who are. And I think that's where private industry can really start using technology and data to move upstream and keep that house from burning, and keep us from only being able to react when it's on fire.
Craig?
I can add, I've often, within the past few years at least, kind of framed suicide prevention, say, I don't like to think of it as like keeping people alive. It's creating lives that are worth living. And that's where I think private sector plays a major role, because if we have good well-being, if our lives are meaningful, we have good relationships with others, we enjoy our work, those sorts of things. All of that is some of what prevents people from heading down those pathways towards suicide. And so I often challenge, when I'm in conversations with leaders of various organizations, to say that's how actually you could be thinking about suicide. You don't need to have to do all these trainings and briefings on here's a bunch of warning signs and refer everyone to mental health. I mean, yeah, that's helpful. What you actually can do that's probably be way more impactful is ask the people in your organization who work for you or in your community, what makes life miserable for you and what could make life better, and then do something about that, because those little things can actually make a significant change. And then I'll say one other piece, just based on my engagement with the private sector around suicide prevention activities, probably not surprisingly, as a clinical psychologist, it has been more of like healthcare services, digital therapeutics, things like that. And I do think there is a major role for the private sector in that place, because I think it's been interesting to kind of partner with companies around technology, things like this, and the way they think about, impact, or how an intervention or a product can be developed and tested is very different from academics. And I think that there will be a lot of advances made outside of academia as a result, because there's a different culture, there's a different philosophy that I think fills a lot of gaps that perhaps are not the traditional strengths of academia.
Katie?
Yeah, so, when I think about this question, I think a lot about the first time I met Justin at USAA. And it was in 2021, and he said, hey, we do a lot of member research. And one of the top area that our members care about is mental health and suicide. And so we're considering how we might shift our priorities, both at the foundation, but also how to address it within our corporate structure. And as somebody like Craig that works in academia, I don't have conversations with corporate people very much. And I am like, oh my goodness, okay, this is incredible. And there are things to consider. I think that's where, partnering with experts to thinking about how to do that in the best way that fits the culture. One of the things that early on in some of the conversations with large groups at USAA, we would ask amongst employees, raise your hand if you have personally been affected by suicide loss, someone you know or yourself, and almost no one in that room didn't have a hand up. So I think that's the other piece, is to think that it's not relevant to a space or a world. Unfortunately, most people are impacted by suicide in some way, and their corporate culture really is aligned with this initiative of Face the Fight. And I'm so grateful for their perspective and interest. To Craig's point, like the way that they've approached Face the Fight would be different than if it came out of a university exclusively. And I think that makes us smarter, and it extends these resources and these conversations in places that I would never have. Like my in-laws are at a USAA ATM, and they said, hey, there's that Face the Fight thing. Isn't that what you're working on? We've never had a conversation about suicide until Face the Fight, but now we're talking about it, and it has impacted them and their family.
My last question, thank you, Katie. My last question is coming off of that. Gabe, it's to you, and then please, you can also add in, but we do have some questions that I want to get to. So Dave, one of the reasons we brought you on is because you do represent private industry, but you also do research, and you kind of let researchers in to Rally Point, and you work with them collaboratively. And so that's the one thing I think that may be different between a private industry approach and a academic approach, is that maybe research is more baked in with the academic approach. But Gabe, to this point, as we think about new entities doing research, new organizations doing research, where do you think, what is that level of evidence that we need before we start saying, you know what, this looks good? If p-values aren't it, when do we start saying, you know what, let's try it?
Yeah, I mean, I really think like it's a human value judgment that's informed by the numbers. And I mean, I've got and in each particular context, if I were making a decision of, hey, we've got this evidence for some program, do we implement it or not? Yeah, like I mean, so the p-value is certainly part of that, but also like, is there just some face validity here? We've got some evidence that it works. Do we think it should work? Do we think that there is evidence of harm? I mean, we can weigh these things differently. We can say, look, we require, if there's kind of even weak evidence that this is harmful, maybe we don't do it, right? And the kind of the costs associated with it. I mean, I think, it is this kind of holistic decision that just human beings need to make, that certainly should be informed by the numbers. I'm a statistician. I love the numbers. But at a certain point, people need to make these decisions.
Thank you. I appreciate that. I want to go to the audience questions, and please, we're going to try to get to as many of these as possible. Craig, I know that you've talked and you've done some research on TBI and suicide risk. One of the questions from Greg Frey is, where do you see that intersection? And do you think the effect of treating TBI effectively could reduce subsequent suicide attempts, especially due to that linkage that was so seminal in one of your not early, I think 2015 or something like that?
Yeah, yes, I do. And incidentally, we have a new DoD-funded research study. So one of Katie's colleagues at the University of Texas, Hannah Tyler, is the lead researcher on that, where we will be working with military personnel who have sustained head injuries, who are not necessarily actively suicidal. And we're taking one of the interventions that my group's been working on, crisis response planning, and saying, can we get upstream? Because we've learned through our research, what I was alluding to before, the way that this intervention works is actually not, well, when you're suicidal, do these things and it'll help. What we're seeing now in our research is how to know when you're heading into a not good place, and how do you find an off ramp? And that's a big part of what we want to do with soldiers who have traumatic brain injury. Of, sometimes they can be more impulsive as a result of those injuries. And so, can we perhaps help them sort of think through how to manage themselves and how to keep themselves away from heading down that road towards suicide?
Awesome. Thanks. Katie, I'm going to direct the next one to you. It's a broad question, and I'm going to combine two questions. So one of them is, how are all of you treating moral injury? And what's kind of the status there? And Craig, please chime in if you have any thoughts. And then the other question is, could focusing on post-military service purpose, in capital letters, purpose, be an anchor point from which to launch conversations into interest, skills, barriers, etc.? So I realize there are two different concepts, purpose and moral injury, but enough related in our next 12 minutes that hopefully you can address them both together.
So I think, moral injury is, a really diverse concept and presentation that, when someone is also presenting with PTSD, then we might engage in some first-line PTSD treatments and look at the beliefs around that moral injury and values. But for some people, there is not a connection to an underlying PTSD, depression, and, seeking support through faith communities, chaplains, talking about that is also another route that people explore. There are other programs, peer-based programs for moral injury too. And Brett Litz has some work with an intervention called adaptive disclosure. So I think part of what we want to think of is really considering the whole picture and how moral injury is related to other things, which may also include suicidality, and looking at interventions for that. Related to purpose, I think that this is really key as humans. And it also aligns with our values, what's important to us, and how do we move closer to that? And to the question of, is it a good entry point? I think it's an amazing entry point to getting closer to supporting somebody that you care about. And helping to facilitate or explore what's getting in the way of that. What would it look like if we had a magic wand? Because I think oftentimes, when people are struggling, they feel stuck, and our ability to problem solve and see bigger solutions may be kind of clouded. So I think that's a great entry point to explore.
Great. Okay. I'm going to go. Oh, sorry, Craig, did you want to add?
I was going to add again, for me, doing mostly clinical treatment research, we really approach moral injury as sort of a type of trauma. And we've classically, I think, thought of PTSD and trauma from this like fear perspective, right? You worry or you feel that you're going to die. And so you have this sort of, kind of permanent fear reaction, something like that. But what we realize is that there might be different types of traumatic experiences, some that are more guilt or shame related, some that are more like anger related. And that, I found it helpful to think of moral injury in that way. And so to that end, we conceptualize this as a traumatic experience, and we've had a lot of success treating moral injury using some of the leading PTSD therapies.
Awesome, thank you. This is, as if people know me, this is a question from Melissa Camo, and it's a great one. It's one of my strong beliefs. And I'm going to rephrase your question, Melissa. I hope that that's okay. And I'm curious, there are there are caregivers who are worried, whether they're spouses, parents, children, that are worried about suicidality among the person they're caring for. Are we supporting them? Are there specific interventions that you know of that can help them be kind of instrumental players in preventing suicide, but also kind of simultaneously offering them support? Dave.
Yeah, I'm happy to jump in. So we've, in fact, Melissa was one of the people that helped educate me on the plight of the caregiver and just how isolating that experience is. And I've learned from many of the researchers and academics in the space that isolation is really that, that last stop before suicide. And so, you can come onto our platform and identify as a caregiver. We have a lot of people who talk about caregiving on Rally Point, but we know we're not doing enough, and we want to do more. And even the whole idea that like right now, when you come to the site to identify as a caregiver, it's as a civilian, but we don't let service members or veterans formally in their profile. Like it's difficult. So we try, but we want to do more. So I'd be very eager for people to reach out and let me know your ideas on how we can do more for the caregiving community. Because especially as I see some of my friends who've had their combat injuries and other injuries in the military age, and their children are having to work with their challenges. It's not easy, and then those children working with their grandparents, definitely not easy. But I think that connection and finding people online who can share stories and how they're finding resources has been helpful.
I also want to just, I'm so grateful to be working with Elizabeth Dole Foundation as part of Face the Fight. And their advocacy and programming for caregivers is so critical. And I think it's fair to say, echo what Dave is saying, we're not doing enough. And more needs to be done to support and help caregivers. I wish that there was a magic wand around that, because we need our caregivers, and they are so critical, and more is needed.
Great. Thanks, Katie. We have 5 minutes. There are 2 questions in the chat that seem somewhat related. Unfortunately, one of them is from somebody, a loss survivor, somebody who lost her husband to suicide, and really sorry for your loss, and for many of you kind of on the call who are loss survivors. The question though is we want to do something. We don't think that there are enough resources in our community. We want to launch something. We want to start something. Any advice on where to start?
I think when it comes to loss survivors, TAPS is an incredible resource to connect with and talk about their programming and what they're doing, what's available in your community. And the American Foundation for Suicide Prevention. They have post-vention interventions called, it's a one session where you talk to somebody else who has had a recent loss. And it's also something that you can volunteer to do. So I think those are two places to start, and I'm deeply sorry for your loss, and I'm glad that you're joining us today.
Thanks. I'm gonna at least, hopefully we have more, but I'm just gonna ask this one question, just because it seems like it's really well poised, especially given what we have. So, and it's a two-parter question. The first is, we're talking about a lot of technology, but so many theories of suicide prevention are focused on connections and interpersonal connections. Our technological, and Dave, you're on, and you are CEO of a social connection kind of website. And I'm gonna have the two-part question is, are we losing that? Do we need more social connection? Can technology be the key facilitator of this interpersonal connection? But then also I want to just pivot, Gabe, we did a report a few years ago that all these groups are trying to promote social connection, but very few of them have been evaluated. So we don't actually know, whether they're actually achieving. So I wonder if you have any thoughts. So Dave, I'll start with you on the technological aspect of social connection.
Yeah, that's a great question. As the father of 3 kids, I wonder about how technology is improving, augmenting, degrading social connection at all levels. And I think we're figuring that out. And I think it's going to take people on this call now and researchers and technologists to lean into how we're going to figure out to make it tools for good and not tools for distraction or addiction or negative activities. Because the dopamine that fires when you're using tools, and some social websites create negative interactions because it increases time on site, it increases clicks to advertisers, it increases ways to drive revenue that are detrimental to mental health. And most social media platforms are not designed to improve mental health and quality of life. And that is something that I do think we care a lot about. And I think any organizations that you all decide to work with, you should make sure that is part of the core values to work with, because we are in the Wild West of that space, I do believe.
Gabe, any last 1 minute?
1 minute. So my one word response is just continuous monitoring, continuous evaluation. Try things, but after you implement them, at some point you do need evidence. And if it never shows up, then that is a situation where maybe you try something different.
Great. Well, it's 4:59 East Coast time. I just want to thank everyone. This is such a dynamic conversation. We could have gone on forever. I'm so sorry to the people in the chat and asking questions. If we didn't get to your question, please know that we tried as best we could. Thank you to Face the Fight and USAA and Justin for joining us at the beginning. Thanks also to Ben Senator for leading us through or kicking our discussion off. I really appreciate it. And thanks, of course, to everyone who joined. This will be recorded. We'll send out the recording to or this has been recorded. We'll send out the recording to all of you and to everyone who registered as well, and look forward to hearing your thoughts. Please stay tuned, come to more of our webinars. We look forward to seeing more of you soon. Thanks, everyone.